Good evening to one and all present here. We shall begin today's webinar. As people start joining, I will introduce Nurseslabs to everyone. First of all, thank you for being here on this platform. I would gladly like to welcome all on our Nurses Labs platform for all your nursing needs. On behalf of all the Nurses Labs team, I would like to extend my gratitude to all who have registered with us today. Especially, I would like to thank each and every one of you all for your support during this time. This month, on the Patient Safety Week, we would like to present to you our day one of the webinar. The themes being advancing patient safety, best practices, and AI driven strategies for early risk detection and monitoring. This topic will be taken by Dr. Puvaneshwari, and the second topic for this session will be taken by Mrs. Renu Elizabeth on the topic Safe Care from the Start Key Strategies for Preventing Harm in the Neonatal and Pediatric Care. Before I introduce to you the speakers, I would like to introduce Dr. Puvaneshwari Kanagaraj. She's not a stranger here at Nurses Labs. She has been very active in all our previous sessions and webinars too. I would like to give a brief introduction about Dr. Puvaneshwari. She's currently working as a assistant professor, University of Bisha, Saudi Arabia. Ma'am has around 25 years of experience in nursing education and clinical practice and holds academic and administrative roles, including a lab coordinator, training head, and program coordinator at University of Bisha. She has exceeded in her academic excellence. She's a gold medalist and best outgoing student, BSc first rank, MSc, and PhD distinction from reputed universities. Ma'am is a recipient of a prestigious award such as the Best Employee 2020 and Best Teacher 2025. She is a resource person in 35 plus national and international conferences, webinars, and award winning presenters and evaluators. Ma'am is a prolific researcher and she has authored more than 23 numerous Scopus and Web of Science indexed and peer review publications. She's an editor and peer reviewer for many journals. We welcome you here, ma'am, once again, and over to you.
Thank you, Ms. Tanya. Good evening, everyone. It's like a great privilege to join with Nurses Lab. So I thank everyone, including the organizers as well as the delegates, to join us today for the webinar on celebration of Patient Safety Week. As Ms. Tanya said, like we have a 3 days webinar. So without much delay, I'll be sharing my slides as a part of the first session. The topic which is given for me is advanced patient safety, the best practices which we have now, and the artificial intelligence driven strategies for the early risk detection and monitoring. So in this session, I'll be focusing on a few topics like the historical perspectives and evolution of patient safety, and why this patient safety matters in modern healthcare, and what are the common sources of patient harm, and to overcome these harm, what is the patient safety action plan which is created by WHO, and what are the key challenges in patient safety as well as its management, and how this artificial intelligence helps us in improving the patient safety, and what is the difference or a comparison between the AI and the traditional healthcare tools, and how much we have opted the AI in India as well as with the other countries. So with these objectives, I'll just want to say a few things about our theme. As we all know, World Patient Safety Day, which was celebrated on September 17th, 2025, but we celebrated for a week. The theme of this 2025 is safe care for every newborn and every child. So it mainly focused with pediatric, with the slogan of patient safety from the start. I think we have a second resource person. She's talking about related to this theme in a detailed manner, but we have a different sessions. With this theme, we are mainly focusing on safeguarding children from preventable harm in healthcare and promoting a safer and healthier future from birth. So as we all know, patient safety is not at all an option. It is a responsibility of everyone. And safety in every step, like we need to have a care in every touch. So with this introduction, we will go into a definition of patient safety. So what do you mean by patient safety? So when you are looking into the definition, which is given by a World Health Organization in 2019, they say patient safety is the absence of a preventable harm to a patient during the process of healthcare and the reduction of risk of unnecessary harm, which is associated with the healthcare to an acceptable minimum. So this is what a patient safety is. So mainly they focus on a preventable harm, which can be done. With that, we will be giving an improved patient outcome. So when we look into the historical perspectives or the evolution of patient safety, it is not new. It is started from Florence Nightingale period itself. And 1820 to 1910, during her period, we would have read her history many times. Like she emphasized on hygiene, sanitation, and systematic patient care in hospitals. With the effect of all these practices, she reduced an infection rate and mortality rate during the Crimean War. So these are all information she had given in her notes on nursing, and she introduced even a data-driven observation and statistical reporting to improve the patient outcomes. So in mid-20s, our focus were like medical errors prevention as well as clinical competence and standardized procedures and nursing protocols. All the hospitals started practicing to reduce the harm in the hospitals. And another one important landmark report, which is there is a book which is called as To Err as Human. The 1999 it was published by Institute of Medicine USA. They were very boldly given a report that is approximately 90,000 deaths in US were due to preventable medical harm. So it was an alarming information for everyone, but it needs to be accepted. So with that, there are a lot of changes had come. They shifted the focus of patient safety in terms of not just blaming an individual, it is actually a system-based error. So there should be a lot of changes we need to have in a system. So that is helpful for making a patient safety. And they recommended an evidence-based protocol safety practices and error reporting, so which will give a very warm health care to the patients as well as a healthcare team. And another one important thing, with all these incidences and reports and statistics, WHO has initiated many patient safety initiatives. In that, one of the thing is World Alliance for Patient Safety, which was given in 2004 to coordinate the global safety efforts. It's not like individual country can do. So there are a lot of protocols, everything is created with the global safety, and published a global patient safety challenges also, which is mainly focused on safe surgeries and medication safety and the practices like hand hygiene. And now we are with this global patient safety goals, which is between 2021 to 2030. The main aim is zero avoidable harm. So with that theme, they are working on. We are also focused. We are also, all countries are working with this particular goal in 2021 to 2030 goal. So with these two things, there is a lot of changes we could see. And why this patient care is important, why this patient safety is important in modern healthcare. When we are looking into that, the first one is definitely it is preventing an avoidable harm, error, and adverse events. So when we are avoiding a harm which can be preventable, so definitely it will be giving a very good care or an improved patient outcomes for the clients. And when we are looking into this patient safety, definitely we are par with the global healthcare standards. So global healthcare standards can be maintained, and always we focus with the patient-centered care, like how we in a teaching learning process, we focus on a student-centered care. Similar way, the patient-centered care is the main focus with the patient safety. And when we avoid this harm or an error, definitely it will be reducing the cost to the healthcare system. So many countries, like they have an insurance they have a governmental, like in countries like Saudi Arabia, there is no need for the patients to pay any money. So the government only will pay for the healthcare to the government organization. So everybody is linked with an, like how we have an Aadhaar card, similar way they have an ICAMA. So with that, they link the people. So automatically government pays for their treatment. So there is no money the patient can spend for them. In that case, a patient safety is followed well, definitely the patient discharge will be little earlier, and the patient is not having any error or a harm which is leading to like readmissions, or which is leading to a bleeding or healthcare associated infections. All those things can be prevented. So ultimately it reduces the cost to the healthcare system. And also it develops a trust. Definitely the healthcare, with the healthcare team, the patient and the family members develop a trust, and we can provide a better patient outcomes and a good quality of care. So with keeping all these things, definitely patient safety to be followed in a modern healthcare system. And this is an alarming incidence which is given by 2023 to 25 by World Health Organization and Organization for Economic Cooperation and Development. So when we read this, really like still we need to work a lot. So the global statistics shows 1 out of 10 patients are harmed while receiving a healthcare, and mainly with medical errors. And more than 3 million deaths occur annually due to an unsafe care. In this, half of the incidents can be a preventable incident. So if we could do that, definitely we can save a life of the individuals. And 4 in 100 patients, that is 4%, die due to an unsafe care, especially in countries like low and middle income countries. It may be due to the practices like the resource constraints or unavailability of a sterile materials, which can lead to a healthcare associated, maybe many reasons. So, or a system error or an organizational error. With that, the death is happening. An economic burden, as we have already discussed, the cost is also important. So when there is a patient safety issues are there, the healthcare expenditure is also very high. So the burden is like trillions of US dollar every year. Indirectly, it is leading to global cost with the patient safety issues. And treating a patient which is harmed during the care, again, that is 13% of the total healthcare spending. It is really a big amount. So these are all the few evidences, again, focusing with the global safety goals. Like we need to work on more. When we look into the errors, there are many errors. So here I have listed few errors. One of the important errors is a medication error. So here medication related harms approximately affecting 1 out of like 30 patients in healthcare. So most of these errors are avoidable. It is preventable. So we need to have a very good education, the practices. So with that, we can avoid the medication errors. Maybe the strategies we will see in the next slides. And another one is surgical error. So 10% of the preventable patient harm happens in the surgical settings. It can be a preoperative setting or an intraoperative setting or a postoperative setting. So this is another one important error. Like even when newspapers or television, we hear sometimes surgery is supposed to be done in the right eye, but it has happened in the left eye. So that is something, an error like negligence, or this is the one thing which we can prevent it. So this is about surgical error. Next one is healthcare associated infections. When it is coming to a healthcare associated infection, a global rate of 0.14 is like each year it is increasing. In that, sepsis is one of the reasons for patient safety. In that, like 23.6% people are affected because of a healthcare associated infections, definitely, which can be prevented, which is even leading to death of the individuals. That is approximately 24.4%. So this healthcare associated infections can be prevented by many of the protocols. When we follow that correctly, we can reduce that incidence. Another important harm is a patient fall. So 3 to 5 times per 1,000 bed days, there is a chance of falling. So when the individual falls, automatically their outcomes will be worsened, especially when they are with the multiple comorbidities, or it's an elderly people, their healthcare will be like outcomes will be very bad. And even it is a burden for the healthcare also, like in terms of a cost. And pressure ulcer in the ICUs, the pressure ulcers rate is very high, like 15 to 20%. And people with a spinal cord injury, again, it is rising to 30 to 40%. So in some activities, like we need to do it in early identification, and prevention can be done with early intervention. And unsafe transfusion practices, this is still happening. Risk of like serious reactions can be happen with the blood transfusion, or infections can be happening, and approximately 12.2 severe reactions per 1 lakh blood components, which is reported globally. And this is what another one, a misidentification. So instead of patient X and patient Y is getting a treatment in terms of surgery or some type of drugs, whatever they give. So this is giving a like approximately 12.3, and it is a sentinel event, which is definitely leading to a serious error. And most of the time it will be leading to a death of the individual. So it may be a wrong site surgery. So this is a recent one, like 2014 to 2017 evidence. This is 12.3 is a very big number. And unsafe injection practices. In this, I have quoted two evidences. This study is from India. Really, when we were reading this, still a basic things which we are not doing, which is leading to greater errors. Like a study of in central India, the government facilities, they found that 45% of injections are unsafe. And the main reason is like poor hand hygiene and lack of gloves. So definitely the hand hygiene can be done. There is no need for any big resource for that. And gloves availability, which is not there. So that is leading to this injections unsafe, which is given by a Thakur in 2023 research publication. And this is by Times of India in Ghaziabad 2024 to 25. They reported that unsafe injections and syringe reuse contributed a big number, like 1,481 hepatitis C virus infection and 691 hepatitis B virus cases. So this is very recent in 2025. So these are all the major sources of harming a patient. So countries like India, we need to keep all these things in mind, and we try to work on these things. So keeping all those things, like the global safety plan, they have created, WHO has created 7 strategic objectives. In that, the first strategy, as we have already seen, according to the theme, that is zero avoidable harm. So the first objective is zero avoidable harm. That is a core principle whenever we are planning a healthcare policies or a delivery, which is focusing on patient safety. And objective 2 is to build a high reliability health systems and organization. So definitely when we have a reliable health systems, reliable organizations, it will be reducing the harm to the clients. And goal 3 is ensure a safety of every clinical process or procedure. So whatever procedure we do, we should follow a protocol. We should follow a standardization of each procedure. So with that, we can reduce the harm. And objective 4, engage and empower the patients and families as an active partner. So not only the healthcare team is involved, even we need to involve them as an active partner, so they will be receiving a better care. And objective 5, inspire, educate, and protect the healthcare workers. Definitely, when we are giving a multiple education and the like these type of webinars also, or like workshops, conference, whenever they conduct, definitely that will be improving their knowledge and recent evidences they will come to know. And there will be a lot of discussions with that. The safe healthcare system can be delivered for patients. And objective 6, it maintain a constant flow of information and knowledge. When we are like the comparing to the previous objective, it is like the information transmission. When we do that, definitely they'll be able to mitigate the risks and reduce the harm of the patients. The last one is develop and sustain multi-sectoral and international collaborations. So this is also an important objectives, like when we are having an international collaborations and sponsors partnership with the different countries, definitely it will be enhancing the safety of the clients and also the quality of the care what we are providing. So before we need to know what is the management we have to do, we need to know what are the failures we have, what are the challenges we have. So this is very evident, these challenges, like every day in a hospital when we work, we face these challenges. First one is communication failure. Then staffing issues, it's a very big problem. Definitely threatens the patient safety. Inadequate reporting and learning systems and diagnostic errors, limited use of technology, patient engagement gaps, resource restraints, organizational culture. Okay, these are all the different challenges we have, but we are not going to discuss so much on these challenges. We will be just seeing how can we manage these challenges. The first one is communication failure. Definitely, unless we give a proper communication from healthcare team, one member to another member, or patient to the, from a nurse to a patient, nurse to a healthcare team members, nurse to a nurse. Yes, we need to be very careful. So how can we report about the patient problems to the healthcare team? So definitely we need to implement a standardized handoff protocols. So there are a lot of protocols which is existing. Even one of the example is SBA. So we always write it with SBA, like situation, background, assessment, and what are the recommendations. When we write that, the other person, when they read, it will be very clear for them, and use a clear checklist and a structured communication tools. This is very important. When we have a structured communication tools, one of the example is IPASS. Here we try to explain it with this mnemonic. I is an illness severity. How is it? How is the patient? And P is a patient summary, where you tell about the diagnosis and the treatment, all the challenges we are facing. And A is an action list, mainly what to do. The to-do list, we can create it. And situation, that is, yes, situation awareness and contingency planning. And the last one is synthesis by a receiver. When we write like that, definitely it will not miss any information. So the communication failure can be managed. And always create a culture of open communication. Whenever we are doing our work, and the environment for the healthcare team should be open. There is no hide and seek communication. No staff should have a fear. The difficulties what they face, they should speak easily. So we should create an environment for an open communication. Definitely, that also will reduce the patient safety by saying their challenges or difficulties. Next one is staffing issues. As we have already said, staffing issue is a big issue. It's a manpower problem. So unless the staffing issue is managed, the patient safety is always a question mark. So ensure an adequate nurse-patient or a staff ratio to reduce the error. Because when the workload is very high, automatically the nurses will be very tired. They'll be very they'll be having a burnout syndrome, fatigue. So that will be leading to errors. And implement flexible scheduling and mandatory rest periods for the staff nurses. And this is another one, cross-train staff to cover a critical area. Sometimes when we are facing a shortages, definitely there should be with the proper rotation. The other staffs also should be trained in those areas. So it is easy to manage a client. Otherwise, when we are recruiting them suddenly to a new place, it'll be a panic situation for them. And recruit and retain the staff by giving a welfare activities like incentives, professional development, and supportive work environment. So all these things, when we do, definitely indirectly it is going to give a good patient safety. Next one, inadequate reporting and learning system. So reporting system has to be improved. We need to develop a non-punitive reporting system like incident reporting system every day. There will be a lot of protocols to be followed that has to be informed to the team members, and implement a regular review and the feedback loops upfront so we can learn things from the incidents. And digital incident reporting also immediately. Whenever the incident happens, we can report it immediately digitally, so that it can capture the data accurately and timely, and conduct morbidity and mortality reviews. So we will explore into that, and we will do a research into that, and what are the errors we have done it. So these all will be helpful for improving the patient safety. And another one, diagnostic errors. So in diagnostic errors, mainly it will be coming with the doctors and even the nurses too. So the second point, what I have told, like clinical decision support system. So it is a digital health information system. So whenever we are making our plan, even it will cross check and it will say a correct decision to us. If we are making any errors, it will be alarm us. It will be giving a reminder to us. So with that, even the nurses or a doctors or a healthcare team, they can identify the errors in their diagnosis. So with that, they can go to a correct diagnosis and correct plan of interventions. And continuous education and training should be given on the diagnostic skills or an emerging guidelines. and follow-up, proper follow-up and monitoring. So these all will be preventing a diagnostic errors. Next one is limited use of technology. When it is coming to a technology, student nurses are very good in using a technology. But the staff nurses, those are above 40, 50, we are still having a difficulty in using a technology because we are not used to that. So, but everyone, whatever is the technology which is implemented in that particular hospital, they need to be giving a clear orientation, and with that, they will be working on with that. So nowadays, the important thing is an electronic health record. So this electronic health record, which has all the informations, and it should be fully integrated. It cannot be like an electronic medical record. If it is changing like an electronic health record, so it will give all the information. It links the information from one admission to another admission, one system to another system, one hospital to another hospital. So all those informations, when they have, it will be giving a very good information. The continuity of care will be there. So in countries like India, still many hospitals are working on with that. And as we have already told about CDSS, that is also very important. So we need to start applying that and train the staff on digital tools and technologies. Whatever the technologies are coming, we need to give a orientation to them. So they will be getting a training in that and work with that. And another one is mobile health solutions. Even this is also like many hospitals we are using now. So this mHealth or a mobile health, which is monitoring a patient, even the patient is in remote area, still we can have a control over the clients, and use of barcodes and electronic prescription or smart pumps. These are all the things which will be reducing even the error. So these are all coming under a use of technology. Next one is patient engagement gaps. So this is another important thing. So it is not only the doctors are deciding, it is always a shared decision making. So with you as well as the patient. So we have to speak to the patients in an understandable way. It is not just like whatever we want, we can tell the information to them in our language, but we need to tell in the understandable language to them. So the patients are also engaged with that, and we can provide up education material to them. And maybe a lot of apps have come. Each institutions, even at tertiary care hospitals, they are having their own apps nowadays. So they can use it. They can tell how they can access this, how they can report their problem through this. Even they can have a consultation with the doctors through the apps, and the monitoring report can be sent to them. So like that, there are a lot of changes are happening. So these has to be informed to the patients. So involve the patients. When we are involving in the care plan and the safety checks, definitely it will be improving a patient engagement, and feedbacks from the patient. That is also very important. So that will be helpful in engaging the clients. And next one, resource restraints. When it is coming to a resource restraints, countries like India or a low or a middle income countries, they have problems in resource, but still we can practice some of the resources which has a high impact and low cost interventions, like a hand hygiene or using a checklist whenever we are trying to take care of a client, and seek for international partnerships or grants or governmental program, so which will be having a safety initiatives, and optimizing a staff and workflow efficiency. And we have to delegate the tasks, or giving a tasks to different people. So these are all the ways we can improve the resource constraints too. And the last one is organizational culture. Definitely the organization should have a very good therapeutic, like how we say, a therapeutic environment for the patient. Organizational culture is very important for the people those are working. So we cannot blame each nurse, or we cannot blame each nurses or doctors. So we can learn from others. It is not blaming of an individual, it is blaming of a system. That's what the change has happened. So regular training should be given, and if there is any safety issues, they need to open up, and any near-misses they can tell, and safety committees can be created, which will be giving a warm environment for the people those are working in that. So ultimately it helps in patient safety. So these are all the key challenges we have. So, and the how to overcome with that also we have seen here. And these are all a traditional way what we are doing it. Now slowly we are transforming into a AI, or an artificial intelligence. So we follow all protocols, checklist, vigilance, all those things. With that digital health, AI-driven strategies now use the real-time data. And it uses a lot of techniques like a predictive analytics or a machine learning or a decision support. So this is helpful to detect the adverse events very early, This helps in reduce the errors and give a very comfortable environment for the patients. So what do you mean by artificial intelligence? So everywhere we hear this word, and every day we use it also, like in teaching learning also, lot of artificial intelligence tools we are using in hospital also. Sometimes like we are using, many of you as a nurses or a teachers or a student nurses or a technicians, you may be knowing like what are the artificial intelligence practices you have in your hospital. So it is a branch of computer science that enables the machines to perform the task that typically require a human intelligence. So for artificial intelligence, it is having its own intelligence to give us solutions for us. In healthcare, even a complex data, when we give, it is trying to give a support to decisions and improving the patient safety and the care quality. So there are different types of artificial intelligence. We are using it in which is relevant to a patient safety. Few I have mentioned here, that machine learning. So this particular AI, which is helpful in detection of adverse events, and there is reducing a medication errors, enhanced diagnostic accuracy. AI is helpful in that, and predictive analytics for a patient deterioration, and natural language processing. Mainly it is used in electronic health records, workflow automation and decision support, and surgical safety and robotics. So we know about robotics surgery, which is happening like a very long time, but now robotics with artificial intelligence have come, and patient engagement and monitoring, and the fraud and risk reduction in healthcare system, and learning health system. So we are going to just see this 10 applications of AI with which are the different AI tools are available and which is used in the hospital setup. The first one is machine learning. So machine learning is a type of AI. Well, what it will do, it is like allowing the system to learn from the data which is existing, the patient data, and improve the performance without explicit programming. So what it will do, it will monitor the patient data, all the informations like a vitals or a laboratory report or an electronic health report. With all those things, it is trying to identify the adverse events, like the risk of patients who's going for a sepsis or a cardiac arrest or a delirium. So when it is trying to identify, the treatment is started earlier, and it predicts the risk of a patient deterioration in the intensive care unit, and identify the client who's going for a risk of fall, and detecting a medication error by analyzing a prescription pattern, how they are prescribing. So it is mainly, it is doing an analysis and giving us an alarm, giving us an reminders. So with that, we work with that. So this ML models are very, very helpful in patients with the hospital readmissions and alert clinicians in advance. Maybe we have few speakers, those are from like US and Dubai. Maybe what are the AI, they use it in their day-to-day, why during their presentations, maybe they will be speaking. But whatever we have in India, I will be able to tell it in the slides. And the next one is under this ML, we are using all these different AI, that is prognosis, sepsis, immunoscore. This particular AI has a 22 immunoscore categories. So it has a variations from like how we have a pain scale score, similar way 0 to 100. With that, again, mild, moderate, severe, like that, they have a category. So with that, based on the information, it will be able to give us this particular patient is risky for a sepsis. So like that, the information through AI, we get it. And based on that, they start working. And NYU Langone AI readmission predictor. This is also very important predictor, and it is working very well with the different countries. So it analyzes the physician notes, whatever they have written. With that, they predict the risk of death and the length of stay, how many days the patient is going to stay, and whether the patient need a readmission. All those things it's be able to tell. And the last one is Akira AI readmission risk prediction. So this is also a AI which is telling about a readmission. But all these AI, every day, day to day, there are changes which is happening. There are refinement. They are doing it with the data, whatever they are getting it. So it will be changing, keep on changing. So whichever AI the institution wants to adapt, they can adapt it. So this is about a machine learning. Next one is reducing medication error. So in reducing medication error, we have different AIs, like it has prescription validation, automated alert, personalized dosing, safe dispensing, and administration. Even in countries like India, we use some of these AI. So prescription validation, whatever the prescription is given, it will cross-check. As we have, this is EPIC is a very famous AI, which cross-check with the drugs, whatever is prescribed for the patient. It looks for the interaction and what is the allergic reactions this patient has, because already we have a data about that particular patient and whether it is contraindicated for this client. So like that, it validate the information or the prescription what is given by the physician. So with that, it is very like helpful to identify or to prevent an error which is going to happen. An automated alert, so it will give a real-time warning for a risky orders, something like opioid, which is not supposed to give it for that particular client. So for that, important AAS, FDB, med knowledge, and personalized dosing. And even it can adjust the dose based on the patient physiological parameters, patient age, their organ functions, all those things, their data, whatever already they are having. And safe dispensing and administration, this, as I had told, like we are using it in many of the hospitals. So this is a machine, like when we put our information, whatever the drugs we want to have deliver, and with a lot of security, like barcode verification or a thumb impression, with that, it will be delivering. So it prevents the errors also. This is one of the AI. So this is our main things which is related to the medication error. Next one, enhanced diagnostic accuracy. When it is coming to an enhanced diagnostic accuracy, even in India, we use these type of AI. What it will do, it will analyzing the imaging, like X-ray or a CT scan or whatever we are giving. It will be able to analyze it and give us a very clear diagnostic accuracy. I have one clear evidence at the last slide related to this. So it helps for an early detection of the problem and reduces a misdiagnosis. Like we may miss something because whenever the informations are given, it will ask us a question. What have you tested this? Have you tested this? Like that, when it is asking back to you, you will not miss any information. So finally, you are coming to a very accurate diagnosis. So with that, we are providing a treatment, even it gives a second opinion. These are all the different examples of AI, like DeepMind AI, IDAC, and ALLCore. So these are all the AIs which is helpful in different area-wise, the specialty-wise they are using. Next one is predictive analytics. Predictive, it is something predicting what is going to happen in the future based on the past as well as the present data of the particular client. So with that, it is very, very helpful. It is something like in ML, how we have identified the adverse event. Similar way, this also like work together. Early detection of sepsis. In this, the main thing is EPIC sepsis model and predicting a risk of pressure ulcers, Quantus AI, and other adverse events can be identified by Microsoft Azure, whichever is highlighted in a different color. These are all the different AIs which is existing, which is helpful, and there are a lot of researchers are going on with that. So with this predictive analytics, it is alarming a nurses or a healthcare team 24 hours ahead what is going to happen for this client. So the intensive care can be given for the patients, and we prevent further complications. And this is an interesting AI, that is a natural language processing. So it is trying to understand our language, interpret and process it and give a data. Human language can understand. So it is applicable in many things like electronic health records, monitoring the clinical notes, whatever we are writing it in the case sheets, look for an adverse effect or adverse event or an allergies, and assisting in automated documentation. We will see these three, what are the AIs are available. When it is coming to a data extraction, it identifies the key entities, whatever they have written in the case sheets, it will be reading, and it when it is put it into the data, it will be able to check all the entities whether this informations are okay, and even from the unstructured text, it make that information into a text, structured text. So that is the way it works with. And safety monitoring, as we have already told, it is trying to understand this drug event based on the patient data. This drug is okay for this particular client. And automated documentation. This is an interesting thing. When the doctors and the nurses, or a doctor and the patient, when they are communicating with each other, even that time, the sound waves, the speech, it will be trying to record it, and it will be giving it in a text information. So here the doctors are they are saving their time. Inside of a bedside, documentation can be done just by their speech. It is recognizing their voice and taking it into a tool and make a structured data But one important thing, they need to cross-check what they have said and what it has extracted is it same. Otherwise, it is a very good information. And there are different AIs which I have mentioned here: Apache, Spark, Apache, CTEX, and Nuance Dragon Medical one. This automated documentation is the Nuance Dragon Medical one, which is a speech recognition AI model. Next one is workflow automation and decision support. Here, again, automated reminders, it will be ensures the timely medication administration to the patient, lab tests, and vital signs monitoring. Especially this will be very helpful when there is a shortage of nurses or a shortage of health team members. So we may miss something to the patient. So it gives an alarm to us. And it gives a checklist and protocols. When we work with all these checklists like bundles, like safety protocols, all those things, when we are following, definitely it will be giving a very good result in patient safety and clinical decision support system. This we have already discussed, so I'm not going into that again. So this is the way the workflow automation and decision support. Here I have given a few AIs in this ADA, Sensely, Cerner, even in Narayana Hridayalaya, the hospital in Bangalore, they were using before ADA, not now, like maybe 22, they were using ADA for saving the informations and to the workflow automation. It was very helpful. So they are changing the AI when different institutions or tertiary care hospitals, they are using some AI. When they get a better AI, they change from one AI to another AI also. So these are all the different things. So it can work with the different things like AI chatbots. Like a way when you give information, it will be asking you a question and it's sending a reminder to you. It gives advice to you. So with that, the treatment can be done. And virtual nursing assistants provide medication reminders and smart CDSS platforms. So these are all the different automation workflow systems, which is helpful for a decision support. Recent study in 2022, they say a systematic review which is when it is coming to a systematic review, which is with a very high quality evidence, they say the CDSSS very, very important, very, very good to reduce the 50% of medication error. So this is a very important thing. With multiple researchers, they are proving the effect of an AI. Next one is surgical safety and robotics. When it is coming to a surgical safety, surgical robots, we already know one of the famous surgical robots, Da Vinci surgical robot with that physician assistant. But now even it is performing a surgery with an artificial intelligence. So that is the difference with the surgical robotics with AI. So it helps in preoperative planning, intraoperative planning, safe monitoring, and postoperative care. In every aspect, it is focusing much. So even in the preoperative, it analyzes the image or an MRI or a CT scan, and it identifies the complex area, how the precision to be done while performing a surgery. So there are a lot of tips. Even a complex surgeries, complex tasks, it will be able to handle it. So few examples of AI which is given as Versius, Global Medical, Da Vinci system with AI, Mako, ROSA. So these are all the different AIs. They are using it in the surgical robot. And another one is safety robotics. So this few hospitals are using, even in India. The first one, computer vision robots. You can see the camera there. So this particular camera is fixed in one particular area in an intensive care unit. So they will be completely monitoring, or in an MRI where the diagnostic tests they are doing. So there will be complete monitoring. So it is helpful to understand like whether the patient is at any risk, or a delirium patient where there is a high risk for a fall. All those things this particular AI is able to understand. So fall reduction and ICU monitoring, they will be able to do. And medication dispensing robots, one of the example is Omnicell. So when you put your barcode and finger print verification, it will be giving a correct drug delivery. So we can avoid the error. And assistive care robots. So this also few hospitals are using a repetitive work, maybe going and delivering a drug to the place where there is no need for much skill. So going and delivering, or going and giving a drug to the patient, delivery a drug to the patient. Non-clinical tasks, these type of robots are used like Moxie. So this is definitely reducing the workload of the nurse, where there is no need for technical skills or clinical skills. When these robots are taking care, the time for the nurses are more focusing on a clinical activity. So these are all some of the robots. Next one is patient engagement and monitoring with AI. I think most of us are aware of all these things nowadays. Like wearables. When we have a wearables, it tracks the vital signs and activity, but it is linked with the hospital system. So any arrhythmias or hypertension spikes, if it is there for a patient, immediately it identifies and alert a patient. The patient will come to the hospital, so they can start an early treatment and personalized reminders. It will give like with some type of app like MediSafe or another app like My Therapy app, and remote monitoring. So here in remote monitoring, like the continuous, previously we were telling about telemonitoring or that is also a remote, but now it is assisted with AI, assisted with artificial intelligence. So it is little more advanced. So it is avoiding a hospital readmissions and understanding the risks. Example of it is bioformers. So these are all the patient engagement and monitoring AI. And fraud and risk reduction in healthcare. So this is also an important thing, because when lot of data are there, there are a lot of chances of fraud, or like, for example, duplicate submission of documents, like getting a health insurance in two places. So duplicate claims or inflated charges and billings which is not recorded, or billings double time recorded, all those things the AI can be identifying. So it will be very beneficial for the patients also, like Optum and SaaS fraud analytics, which is helpful. And risk reduction in clinical practice. Sometimes the doctors will give an unnecessary test, or double time the test, or unnecessary administration of medications, or overprescribing of medications. So these all things also the AI is able to identify using a machine learning algorithms. And policy compliance monitoring, definitely in administration and organizational structure, it monitors the safety protocols and billing regulations, all those things. So it will be giving a feedback, so with that they can make a lot of changes in their organizational system itself. The last one is learning health systems. So learning health system, like AI is enabling, like when started collecting data, analyzing a data, lot of changes are happening in the healthcare system. It is helpful with the data aggregation, especially an electronic health record or incident reports. With that, it gets a feedback and it integrates the information all over the hospital or regions. And even it is predicting an analysis, like it is able to do a small bit of research also. For example, after doing analysis in the particular hospital, it is predicting that falls occur most of the time in the night, and or some specific procedures. So like that, when it is able to identify, we can do a refinement, or we will be a little careful when we are working with the patient. So trend analysis also an important thing. And continuous learning, definitely through AI, there is a lot of continuous learning is taking place. So these are all the AI driven changes which is happening. But how far we are using these AI driven changes? Like there are two classification I have given. We are doing already a traditional healthcare tools system, but AI, how far? It is little different from that. Starting from data analysis, traditionally we do lot of manual review. We are not, we cannot say that we are not doing it. We are doing it, but it is a time consuming. It needs a lot of manpower and time. But AI is doing it very rapidly, very automated, and even it can handle a large data set. They can do it in a minute. That's what the AI is. And decision support, we are always depends on clinical judgment alone. But the AI, even it gives an insight, it gives an alarm, it alerts us. So with that, little more like it gives a second opinion to us. In that way, it is helpful. Error detection, most of the time, the traditional rules, after the error has occurred, we will speak about the error. So it's a reactive way. But AI, it's a proactive way. Before the error is going to happen, it is telling us this type of error is going to happen. So it's really a beneficial one. And adaptability, there are fixed rules and protocols we have in our traditional thing, but the AI is doing a lot of changes, learn from the new data and improves over time. And scalability, limited by human capacity, depends upon the number of people those are working, but it can work with a lot of different departments, interdepartmental working, or administration, education, multiple department it can work, and it can collaborate and give a data to us. So this is about the usage of traditional and the AI tools. We have a lot of legal and ethical problems related to AI in the patient safety. Since it is just coming up, anyway, we need to still know what are the legal and ethical components we have. One is liability and accountability. So who is liable? Who is accountable for this AI? Whether it is a hospital or it is a person who is creating an AI, the source, or who's liable for that activity, or if any error is happening with that. Data privacy violations. Definitely, the AI has a lot of data, so there is a chance for a breach of data. So that is, again, if there is a privacy violations are taking place, how it has to be managed. So that is a concern. Regulatory compliance. AI doesn't have much regulatory compliance because it is working with the different partnerships. Again, when we started taking it in our institution, what is the regulatory compliance it is following? We need to know. And transparency and explainability also is a question mark. And bias and discrimination. How that the data is given to us. Is there is any difference between one patient to another patient? Is there is any discrimination between the treatment protocol, what is given with the data? So that is also sometime a concern. Informed consent issues. With this, I can tell you that speech recognition AI, that NY, which we are using it, Neon Medical One, where before the doctor and the patient, when they are going to communicate, definitely the doctor has to tell the patient that whatever we are communicating, it is getting texted, it is getting into a structured data through an AI. Because otherwise the patient will not know, like somebody is listening, and because he doesn't write anything, he is not doing any documentation by his hand. He will be just listening, but at the same time, the AI is getting the data into a structured form. So we need to get an informed consent from the patient. So like those things are all, this is one of the examples. So this is all coming under an informed consent issues, and the patient privacy and confidentiality. So the information, how confidential it is, and bias and fairness, even it can be an ethical concern. Over reliance of AI, sometimes some people, like even I can give an example, like when ChatGPT come, when people started working, so many of them just rely on only ChatGPT, not really utilizing their brain. Even recently, when research evidence was showing, the people's understanding and cognition is going down. The learning which is taking place in the children are going down because they get all the information ready-made through these AI like ChatGPT or whatever they are using it. So completely the people are relying on it. So that is also a concern. And equity in access. As we know, if you're looking into an AI, countries like India, we are using AI in a very, very limited way. But countries like US, they are using like a large number. Maybe next slide, we will have that approximately 70% they are using in some areas of AI. So there is a discrepancy between country to country because of a cost or so many reasons. So equity in access is also an ethical concern related to AI. So this is a comparison. I try to get it with the three countries like India, US, and UK. The AI application in India, we started using with the diagnostic support, hospital operations, as well as patient navigation. So not exact, more things related to a patient care. But in US, they use like clinical applications of safe sepsis detection, adverse drug events, like ML they use, or a predictive analytics they use. In United Kingdom, they use it for early warning systems and proactive monitoring. So they are having exactly into a clinical applicability with the patient care. And regulatory oversight in India, it is an emerging framework because it is not still used in many places. In US, it is taken by FDA, and in UK, it is by MHRA. And ethical consideration, India is creating an ethical standards for that. And in US, emphasis on patient-centered AI use. That is their main consideration. And UK, they focus on governance and oversight. And privacy concerns, again, addressing a data privacy issues India is doing. And data security, that is a big concern or ongoing discussions which is happening in US. And ensuring safe use of data for AI innovations. So all countries have their own way of handling this AI. And hospital AI adoption rate, when I try to get it in India, it is showing very, very limited. We are not having a very clear data. Data is very less. Like when I was trying to see, it was always, wherever I saw, it is coming as a limited data, limited national data. But in US, it is showing 71, and even in UK, it is less, like 8%. That much only they are using an AI application with the healthcare or a patient safety concerns. So these are the few evidences. Diagnostic AI deployment, we are doing it. Even this is happening in some of the government sectors in India. These all evidences are government, but in all, many private sectors are using their own AI for their hospital with the collaboration with the partnership. So this is a very evident and governmental sector. So I just want to highlight this here. So AA systems, approximately 17 major healthcare facilities all over the India, they try to take. So 1,50,000 chest X-rays and 1 lakh MRI spine scans. It is trying to identify the problem. For example, if it is a chest X-ray, after taking a chest X-ray, it will be able to understand what is the problem. Maybe a tuberculosis. Immediately, it will be informing to the concerned hospital, and then the treatment will be taken. Even it will be happening in a primary health center if it is an X-ray. So like that, that there is a good precision. 98% of precision is there in pathology deduction with the AI support of radiological imaging. So there's many areas they are doing a research and it is working out well. And another one, AI in public health. Tamil Nadu is piloting an AI-assisted technology with especially a TB monitoring. They call it as NICSHI. So in that, the government hospital, it is helpful for identifying and detection of tuberculosis. That is an NICSHI. Other than that, even cataract and cancers, all those things, this type of AI application, they are using it in a public health, and it is a trial projects going on. And workplace safety, a hospital in Bangalore, they have launched a staff app where they want to immediately inform their problems. So their harassment or any issues. It is not only a patient safety, even a staff safety also. So when it is coming, immediately they can report it through these app, workplace safety, strict actions. Almost 4 harassment cases were, when I was reading, they have taken action through this AI. So these are all the changes which is happening, few evidences which I have put, which is happening in India. So AI definitely cannot replace the clinical expertise. We are just started applying AI in the healthcare system with many areas, AI in a bedside documentation, AI in mild inpatient safety, AI in identification of a diagnosis in all by reading on radiologic images like X-ray, CT scan. Definitely, it will not replace the clinical expertise, and it will be giving a very good central and empathy central to the nursing and medical care. The future of patient safety is not just an AI. Definitely, with the traditional practice, we can integrate AI. So which is helpful in reducing a workload or reducing patient concerns, and we can provide a care with a great concern and accountability with the changes which is happening with the digital health. So these are all the references I have got to make these informations. So I'm thanking you.
Thank you, Dr. Bhuvaneshwari, for the extensive and in-depth session. There was definitely so many points to take back from your session. So we will move on to our next session for the day. And I am honored to introduce to you our next speaker for this evening, Mrs. Renu Elizabeth Abraham. Welcome, ma'am. Mrs. Renu Elizabeth Abraham she's currently working now in the US as a pediatric cardiovascular nurse in Texas Medical Center. And she has more than 15 plus years of experience in clinical nursing and nursing education. Ma'am has completed her BSc Nursing from Government Medical College, Kerala, and her MSc from CMC Vellore. We welcome you here, ma'am. Over to you.
Thank you. So my topic is pretty extensive that was given to me. That's like preventing harm in neonates and pediatric population. So I would be, Bhuvaneshwari ma'am has talked about the organizational or like an outline overview of how AI helps and how it can be used to prevent harm from reaching to the patient. But I would be going a little bit depth into like how as a bedside nurse or like at the unit level, what can we do to protect ourselves and also our little kids like the neonates and the pediatrics. So I'm jumping right into my slides. It is quite extensive, so I'll be touching everything. But of course, if you have any doubts or if you want to elaborate on some of these topics, you can always like drop it on the chat session. So why patient safety is important is like it improves health outcomes. And it enforces a culture of safety, and also it has ethical and legal responsibilities. So overall, I would like to say that patient safety, like if we want to consider going to a hospital, we of course look at like how their health outcomes are. How is the discharge? Hey, is the doctor good? Is the unit good? Do they have enough facilities to treat us or the complications that may arise out of it? So we look at all these things in general before approaching a doctor or a healthcare organization. So similarly, the health outcomes are a really important thing. So most of the hospitals in India or like abroad, they would list out like what is the highlights of their hospital. So it helps us to choose a particular hospital over some other healthcare facilities. Then ethical and legal responsibility is very important. So I was thinking when I was listening to ma'am's sessions about AI and all that, AI definitely makes our life so much easier. Like we are not entirely dependent on paper charting or documentation or relying only on ourselves to get a feedback. But it also makes everything so transparent. So transparent in the sense you cannot hide anything. Even after 18, 20 years, like a kid is technically treated as a pediatric till up to 16 years or 18 years, depending upon the country. And it means that the legal or the court or the anybody can pull out their files or your documentation even after 18 years and can sue you or like sue the hospital. So the main thing from all this is AI makes it easier. It's a friendly companion to us. It ensures safety. It gives you so many checks at different points so that you can like it kinds of remind you, and also it prevents harm and improves safety. But also it makes it very, very, very transparent. No hiding anything. Your documentation can be pulled after many, many years, and then so that is why the documentation is important. I'm sure like even you have been told the same, but when I was learning, they used to tell that, hey, unless it is documented, you have not done it. So whatever you've done, make it a point to document this very, very clearly in medical terms. Then patient safety index consists of many things. Like ma'am was again talking about like hospital acquired infections, HAIs, or like falls, or let's say surgical mishaps or surgical errors, CLABSI, like central line associated bloodstream infection. All these things are quality indexes. Like when the hospital is being audited, they look at all these things, the numbers. So our goal would be set, and if we do not hit the goal, then they are not going to like re-accredit us. So reaccreditation is important for all these hospitals. One, for funding. When they receive funds or money from external sources or from government benefits or even insurance, if some insurance needs to cover a particular hospital, then their healthcare, the quality indexes should be really good. So that is why quality index is very important. And of course, cost effectiveness. So when patients are getting discharged easier and earlier. Like, for example, I guess in India, after cesarean section, it takes maybe like 2 days. But here I've seen that like the next day morning they'll be discharged. So when you get like help from all these automated resources or like the AI and everything, and to cut cost, to make it more efficient, they always do like an early discharge. But it doesn't mean that the patient is not fit enough to go. They utilize all their resources. They streamline their operations in such a manner that there is no unnecessary delay. So these are why the patient safety indexes are important. So now I will go to various subheadings which they want me to discuss. So the next slide would be medication safety. So why medication safety is important in pediatrics is that it's different. Pediatrics or the kids are not mini adults. So in this, it is different because in adult, you have a particular dosaging. Like, for example, if it is paracetamol, okay, it is 15 per kilogram, or like you give like a 600, one dolo or one paracetamol, that is good. The only thing you have to keep in mind is the frequency, like how many hours to, the gap between the medicines. But in pediatrics, it's not like that. It is weight-based dosing. So we don't have a standard dosing because newborn weight, or like even in, it depends upon each baby's weights. And therefore, daily weighing is important. And once the weight changes in a couple of days, like that, you need to change the dosing weight and then recalculate the medicines accordingly. So that is one risk. And it is not easy because you do not learn any of the dosages by heart. You know only like how much milligrams to give per kilogram or how much micrograms to give per kilogram, and you need to calculate before giving the medicines. So at least for your sake, I know doctors would have prescribed it and you have all these AI backup. But again, I'm saying like, it is your license, it is your patient's life in your hands. And since each of these medicines, when it given to the pediatric, it hits them even more because their system is immature. They are not anatomically or physiologically well developed like the adults. So drug calculation is important. So the drug calculation competency is a core competency which needs to be taught and then revised every quarter, if not annually. Again, it depends upon the institution. For example, the institution where I work, we have annual competence, and of course, like we have every quarterly classes and modules to be finished and everything. So variable physiology, then formulation changes. Again, the concentration. For example, let us say fentanyl. So fentanyl, sometimes the syringes would be like 10 mics in an ml, or sometimes it would be like 20. So depending upon the concentration, obviously your doses also changes. So you need to be aware before you're giving a medicine, hey, what is the concentration? Like epinephrine, is it 100 mics in an ml or is it 10 mics in an ml? So make sure you know the concentration. Stick to 5 rides, AI or not, stick to 5 rides. Take a breather, don't rush. When you're giving medications, be yourself. Like if I ask you, did you turn off the gas stove this morning? Did you brush your teeth? Did you lock the door when you step out? You don't really remember, right? Because it comes automatically to you. So never practice medicine or nursing automatically. Like you need to pause, think before you give anything. So I know many of the stuff like okay, paracetamol, okay, fine. You grab the paracetamol, just scan it, or like, you enter that you have given it and administered. You do not really think about it. But pause. Did you check what is the liver function test today? Has it gone up? Or like when was a paracetamol dose given the previous? Sometimes like the kid would have like a fever and previously the nurse would have given it less than 4 hours ago. So there is a minimum frequency gap which should be, or minimum time frame or the time gap before which the medicine should be re-administered, right? So be present. That is a first and foremost rule in everything in medication safety. No distraction zones. I've heard in some hospitals they have a particular zone, like actual spot which is marked in the room where you stand and prepare the medicines. But when you're standing there, that means nobody, not even the doctor who comes, nobody can disturb you. When you're on medication preparation, when you're about to chart your medications, administer your medications, blood transfusions, all this, no one can bother you. And you can say, if somebody is like, hey, stop, I am giving medication, so I do not have time for now, like wait for 5 minutes and then. So this is very, very important, especially in pediatrics, because everything, even like a decimal difference, can hit them 10 times or 100 times more, more, I would say, yeah, it can cause toxicity. Then communication gaps. So communication gaps in this, it's mostly communication gap between the written communication or oral communication. As a rule, do not accept verbal orders. And if it is verbal order over the phone or something, make sure by the time you give the medications, verify the medications from pharmacy, you have to get it written down. Because even though you have like a speak back system, like the doctors give the order through the telephone and you tell them back, hey, this is what you meant, is this the order that you just said? And they would say yes, but even though it is undocumented, so get it documented as soon as possible, preferably before the administration. You can get the things ready, but before administration, get it documented or get the order in the file or like in the electronic charting system. Another thing is simple things that you write, like for example, if it is 0.3, always make it a habit of writing 0.3, or if it is 3 or just 3 milligrams, do not write 3.0, because if that point, if you miss, it's going to be like 30 milligrams. So it is just 3. So things like that. These are the protocols which we need to follow when you are documenting, when you are charting, and legibility, of course, is a big thing. And also, before giving any medications, make sure you know what the medication is. Carry a drug book if you don't have like a drug book in your unit. But the hospitals who are following the electronic charting, they will all have like a drug online. So make sure that you know, and you know what is the major side effects and the interaction between the drugs. For example, if my child is on sedation and the child is going to get diuretic is the one like which helps you giving out more urinary output. Until I know the child well, that I know how the child is going to react, I would not give both of them together, like couple of sedation drugs, couple of pain medications, couple of antihypertensive medications and diuretics. I wouldn't give them together. I kind of like give 1 or 2 together, watch their vitals for half an hour, 45 minutes, see how the baby is reacting, and then go on to give. So this is possible only when you know what you're giving. The main side effects, the main interactions, and of course the frequency, please do check. Especially this is important in high-risk settings and fast-paced settings like emergency department or ICUs, because the kid is critical and the baby is going to react very quickly or crash very quickly. And I also want to tell in pediatrics and kids, we have a saying like they do not tell you anything, or they kind of like fight till the last point and then they kind of like fall. So you have a very little time to react. So main thing is to prevent harm from occurring. So this is why the medication safety in kids is really, really important. Now, the strategies how to prevent is, first one is computerized physician order entry. That means basically electronic charting. So the doctors would put the orders in. And since it is an electronic charting or there's like artificial intelligence behind it, like ma'am has already mentioned Cerner and Epic. So these are 2 of the like electronic charting system, which is obviously like based on the AI, which I have worked with. So currently I'm using Epic. So in this, what happens is like, if you want to give, let's say paracetamol. So when you type in paracetamol, then the dosages would come. Then you select the concentration, then you select the frequency. And so it is already like you have the options to choose from. But again, choosing is your, like it's based upon your knowledge and the patient's pathophysiology. But still, you have like a pre-made orders already made up for you, and then you have to choose the right one. So that would again like avoid mistakes by writing out or like miscalculation and all that. So if because the weight of the patient is already in the system, the clinical condition of the patient is already in the system. So if the medicine that the doctor has prescribed has some side effects or may not have an optimal effect on that particular patient, you will get like a flash message saying that, hey, this patient already has like a high liver enzymes. Are you sure you want to prescribe paracetamol for this patient? Then they will again like, think through it. Next is barcode medication administration. So medication administration, I would say stick to our 5 rules. Whatever you do, whether it is barcode medication administration, whether it is just based on your Cardex system, or if it is like the paper, just writing down in the paper files, stick to 5 writes of medications, because ultimately that's what is really important. And patient identification is a red rule. Red rule in the sense it has to be like based on 2 patient identifier. There is absolutely no excuse for patient mess up. Like, you cannot blame it on the system. I know now, like Bhuvanesha ma'am has already mentioned it, like to improve error reporting and to encourage talking upon that, we don't blame it on the person who has done the mistake, or like, I won't say who has done the mistake, from whose hand it has happened, because it might be due to various reasons. The mistake would have sometimes happened from pharmacy, or it would have happened from labeling it, or anything, just the storage. But just because you are the person who administered it doesn't make you liable completely. So that is why now all the hospitals, or like generally all the organizations, look to system-wide error prevention and rectification, so that everybody is not scared to speak out the errors. So the variances, when you do variance, like when you have an error, you enter it into a variance saying that, hey, this has happened. And the variance is treated only for quality purpose, not for blaming a patient or for giving punitive or punishment to that patient, to that person, or the staff nurses who have administered it. But still, there are some things which you cannot just blame it on others or blame it on the system or something, because one thing is patient identifier. Your patient label, your name label should be on the patient, not somewhere lying around the road. So 2 patient identification is very important, not by the name. It should be by the patient unique identification number. And if there is a barcode, scan it. Do not ever administer the medication and then you think, okay, I will scan it. I'm still in the room. I will scan it later. Please do not do that. So these things are so important in medication safety. And another thing is that if you are already working in adult, this might be very, very uncomfortable to you, even because parents and guardians would be there with the kids 24/7 in most of the hospitals. At least in like abroad, they would be there with the patient. I know in India, sometimes there is only like visitors, but here, even in ICU, it doesn't feel like an ICU. The patient mother and like here in our hospital, it's like 3 bystanders per a patient. They can be at the bedside. So everything would be closely watched. Your every action would be closely watched. So make it a point to tell them, hey, what you're giving. So they might, you will be surprised, because the parents know a lot better than us about their kids and the medicines they are getting. So they would tell you, or they would help you from like dishing out patient harm. Then look-alike, sound-alike drugs. So these drugs, I know we have like various drugs which looks alike or like sounds alike. So these would be stored in different places, like physically apart, or like the labels would tell you that, hey, make sure that this is not this drug, you're not confusing. Then another thing is smart infusion pump with guardrails. So it is our normal infusion pump that we use everywhere, but guardrails means there would be guarding settings in the infusion pump or in the LRS pumps that we use. So when you set the infusion rate, it would tell you, hey, this is over the minimum infusion rate. Are you sure? Or this is a central line drug administration only. Are you sure you have an access? Or when you want to give a bolus, it will tell you this is like above the dose that you won't normally give, or this is like very low dosage. Do you want to go ahead? If you want to go ahead, please override it. So there is a constant messages that would be given to you, just to pay attention, be there physically, mentally. Don't just like, looking around, giving or paying. I know nurses are busy, like really, really busy, even with all the AI and all the help. We are constantly on our feet, but I would say if it is all too much, stop. Stop, take a couple of breaths, calm down. Because when it is out of your hand, if you've already done something, no amount of explanation, no amount of saying that I did not have time, I was trying to do this, it wouldn't help anyone. It wouldn't help the patient. It wouldn't help us. It wouldn't help our license. So be very careful when these alarms or like messages are coming. So other things is what we can help, like the strategy for helping us a standardized concentration. So this is mainly coming from the pharmacy or the organization as such. Like we have standard concentration for particular infusions. And if there is any concentration changes, they would let us know by messaging or emailing saying that, hey, this medicine concentration is going to be changed from this day onwards. Be careful. And then standardized order sets and protocols, which I have already told about, like the order physician's order entry, and then kilograms only policy. Some units in grams, some units in kilograms. No, kilogram is the international standard weight, and that has to be done in kilograms. Now, I am working in US, so here normally when you talk to a patient, they ask you for pounds and ounces, like the weight. But when we are doing medication, it is still in kilograms and micrograms and milligrams, because that is a standardized unit. Then updating the dosing weight frequently based on the weight changes. Other thing is pharmacist involvement, especially in ICUs or like critical care areas. There would be a pharmacist assisting the physician on rounds. They would be there in the unit 24/7, or at least if it is not that advanced, and at least over the phone, like the pharmacy would be easily reachable, where you can ask them about, hey, I have a doubt about this concentration or this compatibility. Can I give epinephrine with milrinone or with heparin? So can I give everything through this one IV line? Are they compatible, or are they going to spoil my line? So all these questions, and then before giving any emergency medication, verified with pharmacy. So they should be always there. So they are the ones who is very familiar with the protocols of the medicines. Their presence would make it so much easier. Education and training, this is very, very important, but I still think like this is from an organizational standpoint, not from personal, like at a individual standpoint. So every hospital should have BLS training, basic life support training, drug calculations training, and drug calculation competencies has to be annually checked, and it goes into your personal file. So if you don't pass it, then you would be given reorientation, reteaching, and then that you need to pass it. It needs to be current and active. And I already discussed about distraction-free zones. Some places I've heard they do have like an overcoat or a jacket kind of thing, which they wear while preparing medicine. So that means if the person is on that particular zone, or they are wearing that jacket or the overcoat, that means they cannot be disturbed because they are doing an important medication preparation. And do not store or handle unnecessary drugs in patient cart. You all know, like patient medications would be outside in the main nurse's cabin, but also we have the patient cart in the room where sometimes we store medicines under lock. So please do not. For example, I will tell you, my patient, if the patient is intubated and today he is going to be extubated, please do not store any paralytic agents in the patient cart. If the patient is extubated, take it away. Don't store fentanyl. Even if it is under lock and key, it has no business to be there. No paralyzing agents. Because when you're on break, you do not know who enters into your patient room. So ultimately, you'll be responsible for it. So for our patient safety, do not store or handle unnecessary drugs. And when you're preparing, like you're switching syringes on the infusions, maybe like you have to change 10 or 12 syringes. Do not take everything together to the patient. Scan one, take it, switch it. Scan the another one, take it, switch it. So do it one, like one after the other, rather than scanning everything, taking everything together, and then, messing it up. Then strong safety cultures. I would say this would take a lot of support from your management team and a lot of courage from our side. If something has happened and the error has reached the patient, we need to report it so that we do not endanger our patients even further. And it is a multidisciplinary, like pharmacist, clinician, manager, organizational leadership, everything has to be collaborated. So that was about medication safety. I know I haven't gone into detail, but if you have some questions, maybe like to a particular things or any practices, please, you can ask later in the questions. I'm moving on to the next subtopic, that is feeding. Again, feeding in many of the organization is considered as important as medication because obviously it's breast milk. So many of them, we do have donor breast milks, but it is not as same as accidentally feeding one kid with other mom's milk. It has safety issues because of infections, and it just, you don't have the consent to feed. Like if it's my child, I don't want my child to be fed with somebody else's breast milk without my consent. So feeding is also, the EBM is also considered like a bodily fluid in some places. So you need like a 2% check before you can give it to the baby. So basic thing is like, in order to avoid confusion, minimize the mother and baby separation. Like in some hospitals, of course, if the baby is in NICU, we need to like separate the baby, and the mother would be in like her OBG ward. But as far as like possible, as far as possible, keep them roomed together, bedded together, so that mom can feed directly, or the breast milk doesn't leave the room. Maybe the mother is expressing it, handing it over, but it is still within the room. So there is a less chance of like misplacing or misfeeding the baby with something else, or like formula and anything. So there is less chance of error. Next thing is EBM should be labeled with time, with patient labels, with any of the drugs that the mother is taking, and it has to be scanned before leaving the room. And that is, of course, if there is a scanning system in your hospital. Otherwise, everything depends upon the label. But make sure you have the MRN number of the mom, MRN number of the baby in their ID band, so that you can match with it and before feeding it to the baby. And also the time like of expression, this time of taking it out from the freezer, and how long you can keep it outside. And then once you start feeding it, it's only good for like 4 hours, any feeds for that matter. So be very, very thorough about the protocols and the policies, and it has to be prepared very hygienically, no touch technique as far as possible. And then the containers you use for preparing it, it should be BPA free. Like if it is plastic, of course it is BPA free. We do not use glass bottles anymore, because of course the safety hazard of broken glass pieces in the feeds. So I know this is not really possible in all the hospitals. It is like a centralized milk preparation where the nurses doesn't make the feeds. The mom will hand us over the express breast milk, and then it is labeled and it is put in the freezer. And from the freezer, there is a department called enteral department, or the feeding department, who picks up everything, takes it to the centralized milk preparation, where they deep freeze it. They can defreeze it. Then whenever your baby needs it, you put in the order, or they check the doctor's order regularly and then take out only enough bottles and then thaw it, fortify it with additions, and then send it back to you. Again, if it is EBM, you need 2% to check before giving it to your patient. So all these would help, feeding the baby with something else which the baby is not supposed to get. Speech and swallow study should be done for the babies to assess their sucking, swallowing, and breathing coordination to prevent aspirations and stuff. Another feeding method is enteral tube feeding. I am not splitting it into everything. I'm just like together discussing the enteral tube feeding, but it includes obviously NG feeding, ND feeding, which is post-pyloric feeding, and also the G tube, like the gastrostomy tube, which you give the feeds directly into the stomach through a gastric button. So the first thing, make sure your tube is in position, either by pH testing. Another thing which I used to do frequently in India was like auscultatory method. You keep the stethoscope and then you inject a little bit of air into the tube and then listen for the gurgling sound. I still do it sometimes when I really do not get a definite pH reading. But the funny thing is that you cannot put it down in documentation. It is only for you. Because it is very subjective. Like, because I am hearing it and I am telling that, okay, I heard it. It's not an objective documentation, objective data. So in that case, that is not valid if something goes wrong. So it has to be either verified by the X-ray or it has to be done by the pH testing. If the pH is not conclusive because of the previous medications that you have given to the patient, it would alter the pH of the gastric juice. In that case, you can always ask your team, and your patient has violent cough, or like the patient is throwing up, like vomiting. So in that case, your tube might move. There is a chance. And if you are doubtful, do not feed. Hold the feed and ask the team to get an X-ray order and do the X-ray to confirm the patient's tube position. So that is, checking the tube is very, very important. Then follow the feeding protocols. Like some would be continuous feeding, some patients would have intermittent feeding where you feed for some time, then you wait till it gets digested, and then you aspirate and let the gas go out and all that. So because the main purpose is to prevent aspiration and make sure that your child, your newborn, does not get necrotizing enterocolitis. That means if the patient is has gastric stress, blood supply is not adequate, especially in patients who are like with congenital cardiac or the heart defects. Their blood supply may not be really great in some conditions. So in those cases, you would feed them like as a high risk protocol where you want to start feeding them because it is very important. But at the same time, you cannot just bulk feed them. You can give like maybe 1 cc, like 1 ml or 2 ml an hour. So it goes very slowly. So, but at the same time, make sure in the X-ray it's clear. The baby is not having like any bloody stools, or the baby is not throwing up. I mean, like not vomiting. So watch for early signs of complications, even if it is aspiration, even it is necrotizing enterocolitis. Make sure you watch for it and inform the team based on it. Then using enteral syringes. This is very, very helpful because I know some places use like a common syringe for the IV as well as for feeding, but having a different set of enteral syringes, which is different in color, it wouldn't even connect to the IV port. So even if you do not think straight and then you are giving something, you took an enteral medication and try to connect to the IV line, it would not get connected by the, and it is like color is different. So it is very vibrant, very bright color, which will tell you, hey, this is an enteral syringe and you're trying to push it through your central line. So that would not happen. So these are some safety checks which helps keep you safe and your patient safe. Then parenteral nutrition, which of course is a nutrition given through the IV line. Again, like it depends upon the physician orders it based on the requirement of the patient. The pharmacist will verify it, but it's you who calculates the rate of administration, and of course the lipids needs a 4-hour break. So all those things, again, you should be very mindful of doing it. And also depending upon your accessibility. Total parenteral nutrition is very hypertonic because it has so many stuff in it. You cannot give it through your peripheral line. So be very mindful when the patient, during rounds, when the doctor is ordering parenteral nutrition, it is your responsibility to tell them that, hey, my patient does not have a central line. So if you are still want to order the nutrition, then maybe make it into a peripheral concentration, a thinned out one, so that it can go through my peripheral line until I can get a central line in. So be aware of what your patient's access is and what can be administered and what should not be. And the rate calculation is very important again. So this is, I'm not going into detail of this. This is like how you prepare parenteral nutrition. So you assess, the first one is assessing patient's history, everything, the nutritional need, and the physician prescribes it. The pharmacy will read through it, transcribe it, and make sure that all the electrolytes are like in place. The patient has what he needs to have. He doesn't have anything like going, which is above the limit. And then the pharmacy prepares it, dispenses it, and we administer it. So before administering, again, 2 patient identifiers, check the order, check the label, check the expiration date. Line should be flushed and see to see the line is proper. And then you start it again. Before starting, get another nurse to verify it and co-sign it with you. Again, it all depends upon your policy of the hospital. One thing I would like to tell to nurses is that if you feel overwhelmed, if you feel that there are so many things going on, I need to stop, I need somebody else to come in and look at my patient, do it. I still do it. Like if it is so much overwhelming, I call somebody, maybe my neighbor, maybe a senior nurse, maybe my charge nurse, and saying, hey, I have done all these things, but I would just like you to come into the room, look at my patient and look at my infusions or my drugs or just check everything, just eyeball everything and see if there is anything wrong. There might not be anything, but it's just like, it's always good to have a second set of eyes on your patient. So that was about feeding. Next, we can go to thermoregulation and prevention of hypothermia. I think I can like quickly go through these slides because this is, I know I've put so much things, but this is all like very conversational, not very deep. It's superficial. So in newborns, we keep, but hypothermia is very, very critical if it is not iatrogenic, like if it is not physician induced. Like sometimes we would need hypothermia, especially after a critical event. We don't want the baby's metabolism to be very high. So we sometimes get orders to keep the patient's temperature between like, okay, 36 to 35, a little bit of cold stress so that the patient's metabolism is not that high. But in normal circumstances, 36.5 to 37.5 is what we aim at. And if it is slightly less, like 36 to 36.5 is cold stress, and 32 to 35.9 would be moderate, and anything less than 32 would be like very severe, which is endangering them. And if you find a patient with a low temperature, don't just turn on the radiant warmer to like full heat, because that is going to rewarm your patient really quick, and there would be like pH imbalances in the blood. So then you have to like crank it up slowly, like 0.5 degrees centigrade, like every hour. Aim it to rewarm the baby like that. But we are not going there. Our baby is not going to get cold because we are responsible nurses. So let's see how we can prevent the baby from harm. So one major thing is that, it's through convection, conduction, evaporation, and radiation. So closed doors, warm blankets, change the nappies and diapers as soon as they are wet. If the baby is like in the delivery room, if the baby is not really sick, doesn't need an immediate resuscitation, then you can even do a plastic wrapping with the head covered with a plastic wrap. I mean, not completely, of course, the scalp covered with a plastic wrap. So there are many methods. Or you can use pre-warmed towels can be used, because why it is very important is that make sure you always cover the head, because compared to the baby's body surface area, the head surface area is really huge. Why it is important is that hypothermia can lead to hypoglycemia and can lead to seizures. It can lead to pH imbalances. It can lead to arrhythmias, which could be fatal. So all these things can be prevented. And another thing is that hypothermia is not always bad. Like it's not always, it doesn't always mean that the baby is just cold. Sepsis, neonatal sepsis, it could be either manifested as a fever or as hypothermia, like lower temperature. Most often in newborns, it is hypothermia. So again, in this context, I would tell about another AI, which Bhuvaneshwari ma'am already mentioned. But in our setting, we use something called sepsis crawler. That means it's integrated into the EPIC electronic charting system. You are putting in your baby's vital signs every hour. If it is an ICU, of course. So every hour, and then baby's lab testing results would be there, X-rays would be there, temperature, all these things would be there. So there is something, artificial intelligence that goes behind the screen, which is not really visible to your eyes, but they would be assimilating all these values. And if something doesn't match, like your WBCs has gone up, or if you're like, let us say your procalcitonin level, some sepsis markers are going up, and then you have a hypothermia, all this, then it would give you a very red alert which says that call sepsis huddle or sepsis crawler alert. You cannot ignore it, because that is one big policy where because again, sepsis is a quality index, and quality index is something that the accrediting agencies and the hospital leadership really, really care about. So they do not want you to mess with it. So when the sepsis crawler alert comes, immediate thing is drop whatever you're doing, call your team, They have to come to bedside for a huddle. They have to come to bedside. It's not over a telephone, nothing. They have to come to bedside, and they know about it, so they would come. If not, you can always escalate it to your leadership, your charge nurse or manager, whoever is in charge. So they have to come to the bedside, make, as I said, it might be sometimes you might have got like a bad vital sign or a thermometer, like say the baby is sweating and you kept a thermometer, your temperature is low, the temperature reading is low. And then, but you know that it is because of this, you can always override the sepsis alert. But it has to be dealt with. If sepsis alert comes, then it has to be dealt with. And then start the antibiotics in the golden hour. So be on it. When the antibiotics are prescribed, call the pharmacy. They cannot take forever to prepare the antibiotics and send it to you. You have to say that it is for sepsis. I need it ASAP, like as soon as possible. Get it, start it. Start it after getting your cultures. Because if you start antibiotics before getting your cultures, again, it would not, your culture results would be bad. So know the policy, what to do when a sepsis alert is coming up, and start the antibiotics as soon as possible. Okay, I know I deviated from the temperature, but that is something I want to tell you, since it is about patient safety and preventing harm, and also like it talks about sepsis. Yeah. So kangaroo mother care is important. Radiant warmers. Other thing is like the warm chain during delivery, like never leave the baby exposed. As soon as possible, it's like a cold chain for vaccination. This is the warm chain for transportation. If the baby is to be transported, make sure the baby is transported under radiant warmer or under incubator. So that was about hypothermia. Next, we move on to pain. This is also like very, very vast and very, very important, but talking from a safety standpoint, babies are very vulnerable to pain, even though they do not scream and lash out at you like an adult patient. Their vital signs changes, their facial expression changes. If they are old enough, they will tell you it hurts. If a second person tell you that it hurts, it hurts. Do not tell them, hey, it was just an injection or it was just like a small wound. Please do not say that. Pain, validated. They say it is painful, it's hurting. It is hurting, because pain is very subjective. So pay attention to it and resolve it. Even if you're whatever pain scales you use, even if it is 1 above 0, like just like 1 scoring, and it has come onto your charting, you need to act upon it. At score of 1, you may not have to do pharmacological measures, like you don't have to give Tylenol or something like that. Tylenol may be starting from like a score of 2 or 3, depending upon what pain scale you use. But what I'm saying is that if the pain, even if it is score of 1, you need to do something. It could be non-pharmacological methods, like giving a little bit of sucrose or like cuddling the baby or just checking the baby. Unwrap the baby, see that none of the IV lines or none of the equipments are rubbing against the baby. The diaper is not wet, or the baby is not lying on like a crinkled sheet, or like not lying on the lines and tubings. So just unwrap the baby, make sure the baby is good, check your IV lines all the time. Because one of the major patient safety problem is leaking IV lines. Extravasation of IV lines, check it every hour. I know that you do not like to wake up a calm, like a sleeping baby, a calm baby, but we have to do it, because that is one of the main things where the nurses or the hospital is being sued legally, and that causes a lot of cost, because extravasation, it just goes out like it sometimes the patient might even lose a limb. So be very careful with all that. And then maybe a tight swaddle is okay. Reduce the noises, lighting, or sometimes mom's scented clothes, like you ask the mom to keep it on her chest so that her scent gets, or her fragrance get absorbed to it, and you keep it on the baby. That will calm them down. So several non-pharmacological methods. Try it. If not, and the pain is increasing, not subsiding, and make sure you chart it after 30 minutes. If your pain score is something, some number, make sure you do something, you chart, you document that you have done these things, and then again take a pain score assessment 30 minutes later to tell that after doing all this was my pain score. If it is reducing, well and good. If it is not, then you might want to escalate it. You might want to consider pharmacological methods like Tylenol, Brufen if your baby is above, ibuprofen if the Tylenol is paracetamol. Paracetamol or ibuprofen if your baby is more than 6 months, or like if the baby is very critical, then you will go for like other drugs like clonidine or dexmedetomidine, fentanyl, many drugs according to your policy. I'm not going into all that, but I have put a dosing of this. Opioids, please make sure you are, as a team, you are looking at the opioids every day at rounds to see if the baby has adequate opioids, or if are we overdosing the kid? Is it time to wean it down? And if you're weaning it down, make sure you watch for withdrawal signs like the baby getting agitated and all that. So all these are really important from a pain perspective. So do not ignore pain. Use an appropriate pain scale. Sorry, this is a pain scale which commonly used like for newborn. It could be NIPS, which is a neonatal infant pain scale. For a little bit older kids, we use flax pain or numerical pain scale, or NPAS is again for newborns. But again, whatever pain scale has been adopted, overall the gist is assess your pain is the fifth vital sign. So overall, assess your patient's pain continuously, listen to them, take action, document it, re-document it, and appropriately escalate it. Yeah, and make sure that you do give appropriate opioids. The doses you should be really familiar with. Again, be very careful when you give the medications. So the next topic is resuscitation. What are the safety concerns we need to keep in mind when you resuscitate newborn and pediatric? Anatomically, it is not easy to resuscitate a kid as you will resuscitate an adult. I'm not saying adult resuscitation is easy, but newborn, they are different. So their pharynx is going to be short, their vocal cords is more anterior. So, and also their occiput, like the behind the back of the head, is protruding. So when the baby is like on the bed, already the head is like anteriorly because of the occiput. And then when you intubate, like when the doctors intubate, it's not easy to get the tube in. So, and also, like checking pulses, it's different. When you give the CPR, the compression, the rate is different, the depth is different, and checking pulses in between, all this on a tiny newborn or a baby, it is super difficult. So anatomically, they are different. Physiologically, they are so much different. So all these cause challenges when you resuscitate. So as a nurse, what we can do is be aware of your role. If you're a bedside nurse, be aware. And again, document, and document, please. Please document what events led to the crashing. And if the baby is, you see there is like if it is preventable, do it. But unfortunately, if the baby needs to be resuscitated, in that case, you should know what is your role. As a team leader, you should be able to assign roles to the resuscitation team before the start of the shift so that everybody is ready. Your patient room, if depending upon the criticality of the patient, either the resuscitation drugs would be in the patient room or it would be in the emergency car. Know the location of the emergency car, whom to call, what is the sliding scale for the, be familiar with the algorithm. And again, like you should know how much the depth of the CPR, like high quality CPR, do not interrupt CPR for anything. If most of the kids, sometimes if the baby is not intubated, then you have to follow the ratio of compressions to breath. But if the baby is intubated, it is continuous CPR, get the blood flowing. So our main thing is high quality CPR. You need to know what are the roles in a code, and then who is the team leader? Only the team leader speaks, and then there is a closed communication to make sure that the team leader says something and you tell them back, hey, I'm giving this much of epinephrine, or I am doing compression, my compression is into like this much, or like, to make it a closed. Team leader needs a feedback. Only then he or she will know that you heard what he's saying, and then you have acknowledged it. So that's a closed communication during resuscitation. From the organizational level, make sure all the staff is BLS, basic life support trained, and this education protocol is easily available. And again, this is also a core competency that you are familiar with the resuscitation protocols. This is an exceptional thing. Patient safety doesn't mean that you have to do whatever it takes in spite of the survival rate. Sometimes, unfortunately or sadly, our kids may not have like a really good survival chances because of whatever condition they are in, and the families know about it. So they might choose to tell you that, okay, I don't want resuscitation. Do not resuscitate my kid, or like do not go for chemical resuscitation, or do not go for like just give them compression. But if you need more chemicals, do not give it, or like 3 rounds of compression, then stop and honor it. It is not up to you to make the decision. It is your legal liability and responsibility to keep the patient from further harm. And that limit is decided by the legal guardians. It could be the parents, it could be somebody else, but legal guardians will decide to what extent the resuscitation should go. And that is, again, like a safety check for your patient. So listen to it and honor it. So this is the algorithm, but again, like but we've already discussed about safety in general. But common things is like standard precautions. If the child is, you see your patient crashing, and then do not run into the first thing. Even when you're flying an aeroplane, they say that if there is a turbulence, you don't like go help your kids. You help yourself so that then you can help your kids or like your family members. Same way, keep yourself safe first. If the patient has an infection, gown up, wear all the PPEs and then go. There would be a minute delay or like a couple of seconds delay. That is okay. That is acceptable. That your safety is also paramount. So then you go into, because that would in turn keep the patient also safe. Like there is no interruption. If you run in and then later you come out to wear the PPE, again, there is going to be so much chaos and interruption. So don't do it. Do the PPE and then get into the room. Other things is like confirming the tube placement. After the tube is being placed, you look at the gas levels or the CO2, the carbon dioxide levels to see, hey, what is it? So be aware of these policies, protocols, educate yourself. From an organizational level, every staff nurses should be trained in safe resuscitation. These are all like how much inches to compress and how fast, but this is all again like it comes in the algorithm, which I'm not going to like really go into detail. The only thing is that the access lines, again, you should know if there is no access, go for the intraosseous line, like into the bone, and then you can push anything through that. Yeah. Then, okay. This is for newborn specific safety consideration during resuscitation. Newborn resuscitation would most often happen in a radiant warmer, that is to avoid hypothermia, because hypothermia can again like constrict the blood vessels. It doesn't make the circulation smooth, and then it can cause pH, like the blood gas pH value differences, which again is going to trigger, the heart is not going to respond very well. So that, and another thing for the ventilator is that once your patient is stabilized, connected to the ventilator, the main thing to look is for like whether the patient is getting adequate volumes to expand the chest, and whether the patient, newborns, again, barotrauma is real. For example, like if you want to get a tidal volume of 8 to 10, the ventilator, what it does is that it would give pressure so that the patient gets that much of tidal volume. But the problem with the newborn one is that their lungs is very friable, very gentle. So what happens is when the ventilator pushes, it can cause pressure trauma, which can again cause like atelectasis, or it can cause the pulmonary pneumothorax. So all these things can be caused. So be aware of the alarm settings. Make sure that the respiratory therapist has set the alarm setting and watch the numbers constantly, document it again. So that was a little bit about the infection, the resuscitation. Moving on to infection control. These are various infections. Again, this is important because these are quality indexes. So QALT is catheter associated, urinary catheter associated UTI. The other one is CLABSI. CLABSI is very important, where you have to make sure that your central lines are clean and neat and doesn't cause any infection. So it is central line associated bloodstream infection, surgical site infection, ventilator associated pneumonia. So any of these things, now what the organization does is that they would make care bundles. So if it is a ventilated patient, they would have a care bundle which is firing, or like you have to do, which is like keeping the head end elevated, suctioning the patient regularly, oral care, antibiotic. So all these things, it is a care bundle, which when you do properly, your patient is safe and you are also safe. So follow the care bundles and like pay attention to the early warning sign and antibiotic stewardship. If your patient gets sepsis, please make sure that the antibiotics are promptly prescribed and delivered to the patient. Of course, hand hygiene. Here I want to tell you something. I heard about discussing like no resources or like small, like limited resources. Gloves are for your protection mainly. There is nothing a glove can do which a hand hygiene cannot. And hand hygiene doesn't take much of resources. Hand hygiene is the number one thing in preventing infection, keeping your patient safe. And I'm sure you know the moments of hand hygiene, but do it. Be really conscious about it. Gloves is for our safety mainly, not for your patient safety. Patient safety is hand hygiene. So central line insertion and maintenance, again, make sure your central lines are very clear, sterile, and it is changed. Lines are changed regularly. Dressing is intact, and maintain its integrity of the central line. So in newborns, it is usually an umbilical one. That is a stop-gap method for some time, or like 1 week or so, till we can get a central line inserted. Okay. Next, quickly into communication and transporting. I'm clubbing communication and patient transport into one because I think like both can be discussed. I'll take like a couple of minutes more and then I'll stop. So communication, already Bhuvaneshwari ma'am has talked a little about it. Make sure when you do the handover, it could be like a shift handover, or it could be when you transport the patient or transfer the patient to another unit. Make sure your patient has the identifiers and you completely hand over the patient data, like the history-wise, what have you done up till then, and make sure your documentation is complete up to that point. Then again, the verbal order feedback mechanism. I told you about that, and make sure that like the patient, the physician gets it into a written form before you are actually giving or doing whatever it needs to be done. You always should have an order written before you act. So the other one is S-bar. Whenever you're communicating, you need to tell the situation, the background, and what is your assessment, what did you do, and what do you recommend. Another thing that we are taught is CUS. CUS means if you are concerned. Sometimes it might be difficult because the physician are kind of like in an authoritative position in some places still now. So what happens is that, but you are directly responsible for your patient. So because it is through your hands, you are giving care. Physician does the order. So when it comes back to you, it is your guilt. Okay, I did something wrong to the patient, it is your guilt. And most often it is to protect your license too. So if you are uncomfortable, stop what you're doing. Tell that you have a safety concern and then stop. So that is concern, uncomfortable, safety issue. Tell them this is a safety issue. I feel concerned. If they are not listening, stop and escalate. Escalate to your manager, get somebody senior to you into the scenario and then involve them. So this is also important while patient transport. Again, keep the warm chain and appropriate personnel and equipment. Before transporting, you need to do a transport huddle, like to make sure that your patient have enough documentation to go with them. Patient identifiers are there, emergency medications are there. On the way of transport, if something happens, you have enough equipment and people to accompany you to give. You might be transporting the patient to CT. What if the patient crashes in between? You should have like an ambu bag. You should have the emergency medication to stabilize the patient. So all these things are there. You might need an anesthetist to transport the patient with you. You might need an RT or the respiratory therapist. So before starting out from your unit, make sure that you have all these people with you. And then keep in constant communication with all these people. Talk aloud, tell them, hey, this is my vital signs of my patient. You think this is okay, or do we need to stop and do something about it? Another important thing, which is again a quality index, is fall, especially during transport. So the patient who is being transported should have like an armband which says fall risk, and should have side rates, or should be like should have restraints on the patient. And document when you have left the unit, what happened in between, and when you reach the destination, and when you come back, do your safety checks again, do your room checks again, because you have disconnected the oxygen, you have disconnected the ambu bag from the unit, you took it along with the patient. When you come back to the room after your CT or after your studies or to a new location, do your room safety check once again from beginning. So that is also really important, and document it. So this was like in a nutshell on various topics I have touched. So hopefully it was useful at least a little bit. So the underscore or like the underlining thing, what I want to say is that be very, very mindful of what you do. Don't let anybody rush you. Don't let, if you need somebody's second set of eyes on your patient, do it. But patient safety is the paramount. And your organization is definitely going to back you up, because most of these patient safety things transcribes into quality indexes, which they need for their accreditation or like just to get more patients to their hospital. Yeah. So for the patients or the hospital's survival, they need to have these quality indexes, so they are going to support you. But again, when it comes to you as an individual, it is protecting your license and protecting the life of the patient who's been entrusted to you. Thank you. So if you have any more questions, you can like, and if we have time, you can drop it onto a chat session or however the organizers wants to do it. Thank you.
Thank you, Mrs. Renu. That was such an informative session on patient safety for pediatrics. And this has really been an eye-opening session. And we have a lot to take back from your session. And we thank you, ma'am, for your time and effort spent. Thank you to both the speakers for this evening.